Hello, my name is Kristin Watson. I'm an associate professor at the University of Maryland School of Pharmacy. Today we'll be talking about monitoring for patients with hypertension as a part of our Under Pressure, a focus series on hypertension. In most scenarios, in patients who have newly diagnosed hypertension or their blood pressure is above goal, we will be reevaluating their blood pressure in about 2 to 4 weeks. The timing in which to reassess blood pressure is multifactorial and can include considerations such as how far above goal is the patient's current blood pressure, as well as does the patient already have complications of hypertension. In patients with established coronary artery disease or heart failure, we may be more likely to reassess their blood pressure sooner than somebody who does not have complications of hypertension. As part of our assessment of a patient's blood pressure in those who are over the age of 65, it's important for us to assess for orthostatic hypotension to prevent potential adverse complications such as the risk of fall. As part of our initial assessment for patients who have hypertension, and as well as those as we continue to move through the treatment of their hypertension, we want to do a complete medication review, looking for the use of medications that may be aggravating their hypertension or increasing their blood pressure. We also want to assess the patient's compliance with medications. It's important to ask patients, if possible, for them to bring in their vials to their visit with you and potentially a pill box if they have that as well. By doing so, one is able to assess if the patient is taking their medications, are they filling their pill box appropriately, as medication noncompliance is a frequent cause of uncontrolled blood pressure. In patients whose blood pressure is not adequately controlled and compliance appears to be appropriate, it's important to start looking at those secondary causes once our medications are optimized. Another important component of our monitoring plan is assessing for efficacy. In each encounter with a patient with hypertension, it's important for us to go through the potential cardiovascular complications of hypertension and determine if the patient has the presence of any of these. So for thinking of a patient and the risk of stroke and assessing for efficacy, we want to ask our patient if they've had any one-sided weakness, slurred speech, etc. It's important for us to ask our patients if they have noticed any visual changes and ensuring that they have routine examinations with an ophthalmologist or an optometrist. In regards to cardiac function, we want to ask our patients about new or more frequent chest pain or worsening chest pain. Do they have signs and symptoms of heart failure, such as shortness of breath, dyspnea on exertion? In regards to renal function, it's important for us in patients who have hypertension that we are routinely checking serum creatinine in patients. The frequency of doing this is again going to be patient to patient specific. In general, it should be checked at least twice a year in patients. Somebody who has known renal disease, we may check it more frequently, especially as we titrate medications or add new medications that could affect renal function. And then we want to assess for the presence of peripheral arterial disease. So this can include asking a patient if they develop any lower extremity pain with walking that is relieved with rest, and components of a physical exam assessing for the presence of posterior tibial pulses and dorsalis pedis pulses, and if those are absent, referring the patient for potential further evaluation. In addition to determining if we're achieving our therapeutic endpoints of treatment of hypertension, we need to assess if a patient is tolerating the therapies that have been prescribed to him or her for the management of hypertension. We want to ensure that the patient is able to tolerate a lower blood pressure, so asking if the patient is experiencing dizziness, lightheadedness, determining if any falls have occurred since lowering the blood pressure. After going through the medication regimen of the patient, we want to ask about specific side effects that can occur and unique to each of these medications. So for example, the presence of a dry cough in someone who is receiving an angiotensin converting enzyme inhibitor. And we want to make sure that we are adequately assessing laboratory data in patients who are receiving medications that may alter certain parameters. So for instance, in someone who's receiving an angiotensin II receptor blocker, we want to make sure that we have a plan in place for when we are going to assess their potassium level and their serum creatinine level, both during the initiation, titration, and maintenance phase of therapy. Here you will find the image credits for this presentation. Thank you for joining us today.